All right. Good evening, everybody, and welcome to New York.
With non-healing left toe wound, fourth digit, dorsal aspect category 5. ABI showed right 0.3 and 11 0.22. His meds are as above. He has a Doppler AT on a dorsalis pedis on the left side. Creatinine is 1.4 and the hemoglobin is 13. This is his runoff diagnostic from a diagnostic angiogram we have here. Get running over here. So severely calcified vessels. You can see in the mid SFA, there's a 70-80% lesion, and then right there in the P2 segment of the top, you have a CTO going all the way down.
What we decided to do was not take further pictures and do everything live for you down. And so what we decided to do at this stage is just to go ahead and first put a stiff glide wire down, and then we tried to track a 7-French sheath over the glide. That wasn't possible. So at this stage, we said, you know what, let's put a 5-French 45, which went very slowly, even that I had to telescope it over the arch. And then Dr. Sharma and I switched out for a what we call as a super core wire, which is a super stiff wire. And then we put the 7-French over that. Now we're just going to do the diagnostics. So this one, there's your contrast. You can see he has diffuse SFA with a focal, probably 60 to 70% narrowing, but in a patient with an ulcer, obviously it's something you want to take seriously. Now, as we come down to the mid-distal SFA, as you take the picture, you have a single vessel runoff by a robust, what looks like a dorsalis pedis to the foot. So again, he's a Rutherford 5 patient. He's got a small ulcer, not a large ulcer, but you do need to get some sort of direct line flow, straight line flow to the foot. You can see he has a short segment a popliteal occlusion that's quite complex.
Yeah.
And then he has a mid SFA lesion that's 70%, but just opening that is not going to heal the lesion. We would definitely start with dual access here. You really can't see the ostium of the AT. So here's a trifurcation. You see there's a large collateral, there's the popliteal comes down, and I don't see a good ostium for the anterior tibial for us to get into.
It actually almost looks like the AT has an anomalous origin. Even
it could be part of the perineal.
Exactly,
but I think that's why coming from below with a wire is going to help you a lot. In the past, before we were doing retrograde access via the pedal, we were actually just going ahead and just trying from above, or maybe having to go antegrade.
Yeah.
But the algorithm of adding pedal access has really changed our ability to be able to go ahead and take on these challenging lesions. But the idea is that we're not going to put a sheath in. We're just going to get access. You're going to see Dr. Sharma's going to use a ultrasound, identify the veins, and he'll talk about it. But to build on his point, we were actually doing this all under angiographic guided access.
But again, the main teaching points, obviously try to go above the ankle. You don't want to go too low. The artery is usually very well defined. He has some more calcium, has some more of a pulsation. If you compress, with pretty gentle pressure, remember this is a CLI patient, so even more than regular pressure will compress all three. So the key is to kind of use just a little bit of pressure, enough to collapse 2 of the veins, which you'll see will not collapse the artery. Plus,
he will compress with mild compression. He'll be able to compress both the veins, but not the artery. So don't be fooled by that if you can't compress the artery, that it's not the artery. So fluoroscopy is going to help you because it may still be in the posterior wall, and there goes the wire. I believe, yep, straight up, okay, and no resistance whatsoever. So, and you can see as the blood comes, we are perfectly in the artery. So at this stage, what our system here is to put a dilator. Don't put the catheter, and don't put a sheath. So we're using a micropuncture stiff dilator to go in that Dr. Jaffer is giving to Dr. Sharma. We're going to put this in, and then we're going to give a radial cocktail. And you can see, so it is a true occlusion all the way up. So at least we have this. So at this stage, I'm going to ask for a hydrophilic wire. Give us a command wire, guys. And we're going to try to enter this. It's a very soft wire. I'm a little concerned.
Yeah. Taking the transit catheter through the skin
dry gauze
without a sheath is usually quite challenging. The combination of a dry gauze in the hand and lubricating the actual access site usually kind of helps.
Can we down below, bro?
Slowly make it.
So now I'm just going to take it up as Dr. Jaffer gives me a rail. And then I'm going to let Raman just wire it because he's closer to the wire.
See where it
goes. I'm just going to take it as far up. What I want to do now is leave it there. I want to actually come from above with a wire. So Ray, give me a command wire from above. So we've got a anticoagulation with Angiomax. We've got our 014 wire from above, from below. And now we're coming with an 014 from above with I just need a shape maker. And I'd like now you can see Dr. Sharma's wires down below. So we're both, so now he has a target, I have a target. We're just going to do a quick DSA here.
Yep.
So DSA, yep. And we know it's a small segment occluded from here. And there's our little stump, right? So now we are definitely in two different planes. So we're just trying to see where it is, because the anatomy is not good anatomy, right? So where does the AT take off? Where does everything take off? See, that looks pretty good to me.
Yeah.
So I'm pretty happy with that. I think we're pretty good with a high takeoff AT here. If next thing I may do is ask Raman to wire that vessel from above and then come down and try to meet me this way. So in that collateral there. There we go.
That looks nice.
Do that. So from the fibula to the tibia at the upper 1/3 of the tibia and the fibula, it should make a turn, and it did not make that turn. We're going to see, which is the AT. The AT is down below. So you got to come down, Roman, and then you see the AT takeoff below. Yep, right there. That's the AT takeoff. Good. So now he's going to put it there, Flora, for me. I would now probably switch from above to a micro catheter for him. So this way he doesn't put an 018 Trailblazer in here, Roman. Yep, and he is in the right one. You could see. So now he's going to follow that all the way down to where my catheter is. So we picked an 018 Trailblazer. It's nothing but a support catheter for the coronary aficionados out there. It's a support catheter from I believe one of the companies, Medtronic, I believe. And so what we're going to do is we're going to use this to go in there, and we're going to pick an 018 wire so we can change wire catheter, so we can change to stiffer wires if we need to. It's a long route. So there it comes. So there's a catheter with a nice clean marker. So now pull the wire back and just push the catheter forward. Yeah. Okay. Yep. Stop there. Perfect. That's it. Let's see. Hopefully once something will cross. Looks like I'm not going to cross. I may or no, I did not. Go to another view here, Roman, for me. So you can't make the occluded vessel verse. So he just has to be careful as he enters.
Are you in?
No, I don't think so. Go to another view. So we're just going to go forward with this wire. So remember a couple of things. Dr. Sharma has to make this bend here. Right? Keep coming. Let's see where it goes. So there's the bend. Now slow down, slow down. So I'm just going to pull this back for him, Flora. Okay. Keep coming down for me. Keep coming. So, okay. So it's make it point a little medially. There you go. Okay. Yep, we're in. Flora.
And sure.
So you can see now we're in the vessel.
Good.
Yep. Now so everybody at home saw the technique that Dr. Sharma and I used. So now what I'm just going to do is just pull this back.
Do it again.
So we're just going to externalize this wire, right?
Right. It depends on which one you end up choosing. I think, as far as ones that you definitely don't want to do once you have a dissection reentry, one of them is 100% it will be some form of orbital atherectomy, even rotational atherectomy here. So,
yes, we use bypass. So you can see now we're across. We're just going to put it deep in the foot.
The goal is to also make sure you go past where you had access in case you have to any further.
That's fine. I mean, you just have to make a point the other way if you can go into the main vessel. So we're just trying to. It's very tough to torque from above, as Dr. Sharma said, because of the tortuosity.
Get a torque around this.
Get a torque around this, but we'd like to get it deep into the foot if we can. You have to make sure you didn't push the sheath back in the iliac. I doubt it because there was a lot of friction, but anything can happen. And the answer is it did move back. So this is a major issue. I'm glad it happened here so we can show you how to deal with it. So what you want to do here is now slowly pull the sheet down. You don't want to push. You want to just pull it, fix your balloon and pull the sheet down. So the balloon is going to act as your catheter and the sheet will go forward slowly.
It's very important to look at the distal edge of the sheath. It's right at that turn. So you want to be very, very careful as you're going down because you don't want it to aggressively make a turn.
I think that's enough.
Yeah, I think this is.
So what we're going to do is we're going to balloon the track.
Yeah.
It's an undersized balloon, obviously. We're going to balloon the track here. Okay. And we need to straighten out the balloon. Pull the balloon back a little, guys. I mean, pull the balloon, just pull it so it doesn't bend like that.
Yeah.
I mean, up here, you see this?
Yeah.
Okay, that's good. Perfect. Now you can go up with the balloon.
How long was this one?
200.
Oh, good.
So we're going to balloon this. We're going to just balloon the track to get it going. Right. So we're going to leave this up a little bit. I know we're ballooning this area, but it's an undersized balloon, so I'm okay. Let's go down. So we're just ballooning now, creating our track before we IVUS. You can see there's another lesion, a very tight lesion, the occluded segment, another lesion. And again, we are now able to hopefully crack this one. Is that a you don't think it's a lesion or air?
That looks like a lesion.
Yeah, go up a little more.
Yeah.
At 10.
There you
There
go.
we are. Very good.
There you
And
go.
as you still see a little napkin ring there.
Yep. Go up again.
All right. 12.
Yeah.
At 12.
Just do the shuffle. Do the Dr. Sharma shuffle. There
Right,
you
just-
go.
yeah,
There
up
you
and
go.
down.
It's a little
Slowly.
bit of a lesion.
Yeah. But we know we're not done yet as
So
far
down,
as
and then we
the
can go further
intervention,
down.
right? So as we pin the wire, we've opened up more and more of this track. We're going to get a different part of the balloon to where this lesion was. So you can pull back a little bit, gain some
Get some
momentum
speed.
again.
Yep.
Good.
Now
Pin the
go.
wire again. You. Right. And we're going to go. And there we are. Now we're all
now
the way
you
down.
can go up. Now you go up
Yeah.
aggressively.
Let's go up again.
And now you can see the end of the balloon is right there.
Yeah.
Now we're creating the whole track for us. And there's our lesion. It's still there. What are you at now? Wow. That's a really tight lesion.
We do a coronary sitting on that,
There it
please?
is.
Did it just pop?
Mhm.
Yeah.
It looked like it
Oh,
popped.
yeah. Yeah. Okay.
Yeah.
Sorry.
And hopefully we'll have good feelings after this one. And there's your good feelings. So there's your high takeoff AT into a
Yeah.
DP, right?
Mm-hmm.
So now we're going to go ahead down to the. So the technique of atherectomy and in this particular case will be taking the atherectomy catheter, dottering it down, right? Which is what we're going to do right here. I'm not going to cut that angle right there because it's quite a, there's going to be a lot of bias. I'm going to dot it down to 30. And I'm going to pull back to the straight segment, a little bit lower. And then I'm going to torque, Ray, mag up on my cutting device, please. I want to show you the teeth of the directional atherectomy device.
All right.
Mag it up again, sir. More. So now you see that we've now ballooned with a 3.0 balloon. That the sizing of the balloon really matters. So, and I'm really looking for any dissections that I need to tack up or anything like that. No mueva, senor. Okay, you can see here, there's a little dissection there. Oh, not really. I think it's more plaque versus little dissection. And then at this stage here, very nice. And then at the level of when we turn into the ostium, which is right here, that's where we're kind of going to have to stent, it looks like to me.
Yeah.
We're going to stent the proximal. You know, the only question is what stent do you want to use for the proximal?
It seems like it's a pretty long lesion. So
Let's do a
probably
DSA
one of
of the
the
distal lip.
48s will probably
Yeah,
help.
so get us a 3.5/48, guys.
You want to do a DSA? Take a good look at it.
Just do a DSA, yeah.
Yeah.
That's enough to see. Yep, that's it. No mueva. So you can see here as he comes down there, look at the flow right there. Actually, we got to go proximal.
Yeah, it's like 10
We
almost.
got to go all the way to 10. All right, give us the 3.5/48, please.
That should get us mini too.
What?
So we can get the actual CTO area too.
I think it should
Yeah, we
reach,
got
right?
it.
We have it.
We
We
got
have
it.
it. So now we're going to go with the coronary drug-eluting stent. And I'm not worried about crushing this area as much. You know, I don't think it's going to be a big issue here.
Yeah.
So we will go proximally. They do really well. So it's such a tortuous one that the stent is giving me.
Was that the
Okay,
proximal lesion?
Maybe. No, I don't think so. Okay, it's the arch. Okay, so
Well, what do we know, right?
Right there?
Maximal medical therapy. I like that.
I like that. Go up.
Maximal medical therapy. What does that include? I would say first and foremost, risk factor modification. So smokers need to stop smoking. You need to make sure, stay still, my friend.
What are you at?
12.
14.
Smokers need to stop smoking.
Go up.
Diabetics need to be on insulin, metformin, whatever they
Yeah.
need based off what their A1Cs are. 80% of patients were on a statin, which is not something that you see very commonly, but it's nice to see. And then the question comes down to what is your antithrombotic, anticoagulant
Okay,
strategy?
DSA.
The Voyager PAD was the one that had showed.
My whole thing here is just so that I want to make sure my stent is opposed. No te muevas, senor. So I just want to make sure my stent is opposed. And it certainly looks opposed there,
Yeah,
there.
well sized.
A little worried about proximal. That's why I wanted to do this, just to make sure that there's no IVUS issues that would help me want to post dilate this. We did go quite high, and it looks like
Beautiful.
there's plaque, but it looks like it's opposed. So I think the issue here is a focal SFA that because it's a CLTI patient, we want to treat.
Yeah.
So I'm going to just survey Raman and Osman here and ask them both, since Osman is just about to graduate. First, Osman, if this is your patient, what therapy are you going to do there? So what we're going to do is we're just going to go ahead and do a quick IVUS here. And now you see it's mostly soft plaque.
Yeah.
And then there's the lesion right there.
Yeah.
There is the tightest lesion.
Yeah.
So what's the vessel size there?
1, 2, 3, 4, 5, 6, 7 on the
So
nose.
it's a 7 millimeter lesion. So we're using a high pressure balloon called a 6040 Dorado by Bard. It's a Kevlar balloon, or BD, I should say now. It's a Kevlar balloon. And now we're going to go ahead and expand this.
Basically, as it expands.
So you can see the expansion here.
Yeah. So you still see that little neck.
Crack it.
Good. So there it is.
So we're just going to take this down and come back a little. Right there. Perfect. There you go. So that's where we're going to deploy this. Excellent. Get us a 70 balloon, please.
And choose that for a O35R.
Mm-hmm. Should have done it.
Yeah.
But the balloon will do it.
Yeah. Okay. Nice little trade for the road. You know, if you find that you delivered a long stent, and then your next planned step is to do a balloon angioplasty
They gave me an
afterwards.
014 balloon.
Oh, good. Never mind.
No, 35.
Yeah.
What is it? 20? That's fine. 20 is fine. 40 is fine.
Yeah.
So now what we're going to do is we're just going to change out the 035 wire through this balloon.
Yeah.
This way it'll help us walk the sheath out. Okay, that looks pretty good. All right. And since the guy's moving, we're going to go look at the balloon now.
Don't move, buddy.
Okay. So there's
That
the
certainly
flow.
answered the question.
You
Yeah.
see that, we're going to give nitride and everything. We're not going to put him into renal failure because of this. So I think we're going to stop here with 15 minutes left. I mean, if you want, we can show you a per close, or what are we going to do for closure here? Anything?
It really always comes down to what the access site looked like. So I think it's a good time to go over that. Now that the wire is back. Good. Okay. So let's see what the access looked like. This one I would probably leave, to be honest.
Yeah, I think we're going to do manual. You can see you have eccentric calcium in that spot.
Yeah.
So there's not a real good closure kind of situation. So we're going to leave this. We're very careful on who we close. Obviously, this particular one is not something we're going to close.
Yeah.
So we're going to go ahead and use a 7 short sheath. And I hope this has been helpful. Dr. Sharma and I thank you for logging in. It was a pleasure to see you in New York. And of course, we thank our team and the entire AV team for helping us get through this.